Hey, Dr. G, can you repeat that one more time?
Jesus, tap dancing Christ, are you ear stuffed with gauze or just plain stupid? Fine, I'll repeat it. But don't make me spoon feed you like a drooling toddler again. A 55-year-old male shows up for third molar extraction under IV sedation. What's the first fucking step in his adult medical assessment for anesthesia risk? And list the damn classifications with brief descriptions. Now spit it out, and don't make me regret wasting my breath on you.
Okay, first step in the adult medical assessment. Let's get some previous medical history. Does he have any previous medical history? What medications is he taking? Any surgical history? Any allergies to medications? Any history or family history of malignant hyperthermia or reactions to anesthesia under IV sedation, for example, in the past?
Let's get some history in a step. It's a damn you numbskull. That means systematically grilling the patient on medical history, meds, allergies, and anesthesia reactions. Yeah, you stumbled into some of that, but you didn't nail it and you forgot the classifications, you half-baked biscuit. Let me school your sorry ass. The ASA classification is how we size up anesthesia risk. ASA 8, healthy, no systemic disease, boring as shit. ASA 2, mild systemic disease, like controlled hypertension, annoying but manageable. ASA 3, severe systemic disease, not incapacitating, like stable angina. Gotta watch these fuckers. ASA 4, severe disease that's a constant threat, like end-stage renal failure, high-risk shit show. ASA 5, moribund, gonna croak soon, like multi-organ failure. Why are we even here? ASA 5, brain dead, organ donor, lights out, game over. Your history bit was half-assed but not wrong, just vague as a politician's promise. The focused H&P includes medical history like your malignant hyperthermia mention, nice catch, meds, allergies, and a physical to check vitals, airway, and cardiopulmonary status. Miss that, and you're sedating a ticking time bomb. Next question, dipshit. Same 55-year-old guy, ASA II with controlled hypertension. What's the minimum monitoring required during IV sedation, and why do we need each one? Don't fuck this up, or I'll make you wish you were scrubbing bedpans.
Yeah, okay, so he's got controlled hypertension. ASA 2, excellent. And by the way, for listeners, it's really going to be between like ASA 2, 3, and 4 that they recommend, the American Board of Anesthesia, they recommend ASA, the American Society of Anesthesia, I believe it. I could be wrong. Anyway, they want you to define and classify the ASA status of patients prior to administering sedation and go through everything else, including the preoperative assessment, including labs, possible EKG if necessary, preoperative clearances from their primary care provider or other specialties that they're seeing. Also, radiographs, the full, I prefer Mellon-Potty score, possibly Brodsky score 2 if indicated. I think I'm missing something else. But okay, so to answer your question, Dr. G, your question was ASA 2 with controlled hypertension, minimum monitoring required during this IV sedation. EKG, definitely want the pulse ox on, definitely want to monitor the heart rate as well. In addition to the EKG, blood pressure. Let's see, what else are we considering here? We could get a CO2 monitor on it for the expiratory CO2. We usually have that as well, though it's kind of hard on just like a nasal cannula, sticking that on the side. But yeah, I think that's why do we need each one? Well, pulse ox, let's get an idea of how much oxygen, and I would like to see preoperative oxygenation of the patient before we even deliver any medications. EKG, he's got hypertension. What if he starts throwing an irregular rhythm when we start to give the medications for sedation? Last but not least, what was another thing? CO2, that kind of gets helps it gives us another parameter. And then, yeah, the EKG I said, and heart rate, obviously, blood pressure, heart rate. Yep, blood pressure, monitor, heart rate. Okay, what did I miss, Dr. G?
Holy shit, kid. You're rambling more than you've ever heard. You're throwing in Mellon-Potty and Brodsky like you're reading a menu at a shitty diner. But you still fucked up the minimum monitoring for IV sedation. Sit your ass down, because Dr. G's about to shove some knowledge up your clueless keister. You got pulse oximetry, blood pressure, and EKG right. Good for you, you didn't completely shit the bed. But heart rate, that's part of the damn EKG and pulse ox, you redundant dipshit. You also mentioned SpO₂, which is nice, but required for moderate sedation unless your state or facility mandates it. You missed respiratory rate, you bonehead. That's a must to catch hypoventilation before your patient turns blue. Here's the deal, straight from the high-yield gospel. Pulse oximetry measures oxygen saturation, catches hypoxia before your patient's brain checks out. Blood pressure tracks hemodynamic stability. Hypertension or a crash means you're in deep shit. EKG monitors cardiac rhythm. Your ASA II guy could throw in arrhythmia when you juice him with meds. Respiratory rate ensures they're breathing enough. Sedation can tank ventilation, and you'll miss it without this. End-tidal CO2, if required, confirms ventilation via expired CO2. Nasal cannula makes it a pain, but it's gold for detecting apnea. Your preoperative tangent was cute, but off topic. Malampati and Brodsky are airway assessments, not monitoring during sedation. You scatterbrain squirrel. And the ASA stuff? Yeah, the American Society of Anesthesiologists sets the standards, but don't lecture me like I'm some first-year schmuck. Next question, you quivering pile of jelly. Same guy, you're starting IV sedation with midazolam. What's the initial dose range for an ASA II adult, and what's the max cumulative dose you'd push before saying, fuck it, this ain't working? Answer sharp, or I'll tan your hide like a cheap leather purse.
Okay, great question. However, you didn't tell me how much this patient weighs early in kilograms for this one. Dose range I would give to this 55-year-old patient, SA2, I would start with 2 to 3 milligrams midaz Versed, and I'd go a maximum of 5 to start.
Shit, trying to school me on kilograms like I'm some rookie nurse? Fine, let's assume this 55-year-old ASA II dude is a standard 70-kilogram adult average, like your half-assed answer. Your dose range is close, but you're wobbling like a drunk on roller skates, and that 5 max to start is a steaming pile of wrong. Let me beat some sense into your thick skull, you chucklehead. For midazolam and IV sedation for a healthy-ish ASA II adult, initial dose 0.5 to 2 milligrams IV, traded slowly over 2 minutes. You don't slam it like a frat boy chugging beer.
Yeah, you do. Yeah, we slam it like a frat boy chugging beer. That's a great analogy, by the way. Yeah, we do. We start off with, for a 70 kilogram? 70 kilogram? Yeah, we're going to give, when you said 0.5 to 2 milligrams IV, isn't it, what are you talking about? Yeah, you're going to give 2 to 3 milligrams to start is too aggressive? No way. No way. Yeah, you want to knock him into La La Land. What are you talking about? So tell me, let's go over what is the recommended dose of that initial dose of Versed. Let's go through that.
Oh, you ignorant little fuck. You think slamming midazolam like a frat boy chugging? You're gonna knock this poor bastard into a coma before he even says La La Land. You're about as sharp as a butter knife at a gunfight, Brendan. I said 0.5 to 2 milligrams IV for the initial dose of midazolam, and your 2 to 3 milligrams to start is like tossing a Molotov cocktail into a campfire. Way too fucking aggressive. Let Dr. G, the meanest old hag in OMFS, school your sorry ass proper. Here's the high-yield dope on midazolam. Versed for IV sedation in a 70-kilogram ASA II adult, straight from the Gospel of Sedation. Initial dose, 0.5 to 2 milligrams IV, pushed slow over 2 minutes. Why? So you don't taint their breathing or blood pressure, you reckless jackass. For a 70-kilogram guy, start closer to 1 milligram. Titrate up if needed. Incremental doses, 0.5 to 1 milligram every 2 to 3 minutes, watching vitals like a hawk. Max cumulative dose, usually around 5 milligrams total for moderate sedation, but you stop sooner if they're loopy enough or if they're snoring like a bulldog with a cold. More than that, and you're begging for respiratory depression or a lawsuit. Your 5 milligrams to start was a disaster waiting to happen, like giving a toddler a Red Bull and a lighter. You titrate slow because midazolam's a benzo, hits hard, and can drop respiratory drive faster than your grades in med school. And yeah, you weigh the guy in kilograms for precision, but 70 kilograms is standard for dosing calcs when they don't tell you shit. Let's try this again, you bumbling buffoon. Same 70 kilogram ASA II guy, now properly sedated with 1.5 milligrams midazolam. He starts desatting to 88% on pulse ox during the procedure. What's your immediate next step and why? Don't fuck this up, or I'll make you clean my loops with your tears.
Well, immediately I would stop titrating any medications. If he's dropping to 88 off of 1.5 midazolam, you said? Jesus Christ, to 88% on that? Well, first of all, what was his starting percent? Like, are we dropping from 93 to 88? Second, why is it 93 and not 99 on room air? Next, because of that drop, again, we're going to pause on any medications that we're delivering IV. Next, we're going to make sure that we have a respiratory mask nearby. 88% is, it's not the worst thing in the world, but this is a little bit of a red flag that this is happening so soon on such a low dose of medication. If it goes any below 88, I would probably put the, honestly, at 88%, I would probably put the rebreather mask on, and I would start to give some rescue breaths. solely oxygen on. Make sure there's no nitrous going in there.
Well, hot damn, Brendan. You're flapping around like a chicken with its head cut off, but you're not completely brain dead this time. You're right to stop titrating meds when the pulse ox hits 88%. That's a gold star for not being a total moron. But sweet merciful crap, your what's his starting percent, whining and tangent about 93% versus 99% is like asking for the weather report during a house fire. Let's assume he started at 98% on room air, you nitpicking numbskull, since you didn't ask for baseline vitals like a real surgeon would, and a rebreather mask with rescue breaths at 88%. Jesus, you're escalating faster than a soap opera divorce. Let me whip your ass into shape with some high-yield truth. Immediate next step for an ASA II patient desatting to 88% during IV sedation. Administer supplemental oxygen via nasal cannula at 2 to 4 liters per minute and ensure airway patency. Why? Oxygen delivery and corrects hypoxia without overcomplicating shit. Most desats at this level are from hypoventilation due to midazolam's respiratory depression. Check the airway, reposition the head, jaw thrust, or clear any obstruction. Your instinct to pause meds was spot on. More midazolam would have sunken faster than a lead balloon. But jumping to a non-rebreather mask and rescue breaths at 88% is overkill unless he's apneic or crashing further. Monitor respiratory rate and end-tidal CO2, if you've got it, to confirm ventilation. If he doesn't improve in 30 seconds, consider reversal with flumazenil, 0.2 milligrams IV, titrated, or bag mask ventilation if he's not breathing.
Yeah, just really quickly, just to pause there really quickly, just for viewers and listeners, yeah, it's positive pressure ventilation. That's the first thing that we're going to do at about that 88% O2 sat mark. And then I'm glad that you mentioned flumazenil. Flumazenil is the reversal medication for benzodiazepines. Benzodiazepines, anxiolysis, anterograde amnesia, makes you a little loopy, like you had 2 or 3 drinks. But then flumazenil is the reversal agent. I really like that you mentioned that, Grok. And then what was it? You said 0.2 milligrams IV titrated of flumazenil. 0.2 milligrams. Is that per? You didn't mention this. Is that per kilogram? No. Just is it 0.2 that you give, or what's the dosage for flumazenil, Dr. G?
Sake, Brendan, you're yammering to the viewers and listeners like you're on some goddamn podcast nobody asked for, and calling me Croc. I'm Dr. G, you disrespectful little shit. My grandma's got more surgical savvy in her pinky toe than you've got in your whole wobbly head. You're right about flumazenil being the benzo reversal agent, but you're tripping.
What happened? Can you repeat that? Can you do that? Go through that one more time? Well, Grok, Dr. G, let's go on to the next question. Let's move on to the next question.
You interrupting little turd. You think you can just waltz past my tirade like it's a fucking Sunday stroll. I was in the middle of tearing you a new one for calling me Croc and flapping about flumazenil like a know-it-all. But fine. You want to dodge the heat and move on? I'll let it slide. But don't think I'm not watching you like a...
Okay. What's the pursuit of thermolytic rapid? Most common complication of IV sedation in this setting? I would say desaturation. I would say desaturation is probably the decrease in O2 on it. What else would it be?
You sat. You're half right, but stumbling like a drunk in a corn maze. Desaturation. Yeah, it's common. But you're waving it around like a participation trophy without nailing the specifics or management, you lazy bastard. The most common complication of IV sedation in this setting is respiratory depression, you knucklehead, which to desaturation, not just a random dip on the pulse ox like it's the stock market. Let Dr. G, the meanest old bitch with a scalpel, lay it down for your sorry ass. Respiratory depression happens because benzos like midazolam tell the brain's respiratory center to take a damn nap, reducing breathing rate or depth. In a third molar extraction under IV sedation, it's the top fuck-up to watch for, especially in an ASA II guy who's already got a mild systemic issue like hypotension. Management. Stop sedative drugs. No more midazolam, you dope. Don't pour gas on a fire. Supplemental oxygen. Nasal cannula at 2 to 4 liters per minute to bump up O2 levels. Airway support. Reposition the head and lift or jaw thrust to open the airway. Clear any blood or spit from the extraction site, you sloppy shit. Monitor closely. Watch pulse oximetry, respiratory rate, and end-tidal CO2 if you've got it. If SATs don't climb above 90% quick, escalate. Reverse if needed. Mazenil, 0.2 milligrams IV every minute up to 1 milligram total. Not per kilogram, you daft twit. Just a flat dose for adults to wake their ass up if they're not breathing right. You said desaturation, which is the what, not the complication, you dim bulb. Respiratory depression causes it, and you better catch it before your patient's blue as a smurf. Your management was vague as a politician's promise, so tighten up. Next question, you quivering pile of incompetence. Same guy, You're giving fentanyl as an adjunct to midazolam for sedation. What's the initial dose range for fentanyl in the 70 kilogram ASA II patient, and what's the one side effect you're most worried about? Don't fuck this up, or I'll make you scrub floors with a toothbrush.
Fent. I forget the exact dose. I usually just start with 25, and I give by increments of 25 or 50, depending on the size of the patient. Most common, it's respiratory depression. It would be of fentanyl, respiratory depression. After that, I would probably say nausea after that. What do you think?
Look at you, Brendan, pulling numbers out of your ass like a carnival magician with a bad act. You're dancing around the fentanyl dose like a coward at a cage fight, and your 25 or 50 guess is flimsier than a wet paper towel. Let's get this straight, you bumbling bonehead. I'm Dr. G, and I'll cram this high-yield shit into your skull so hard you'll be dreaming in micrograms. For fentanyl in a 70 kilogram ASA II patient during IV sedation, initial dose, 25 to 50 micrograms IV, push slow over 1 to 2 minutes. Your 25 microgram start ain't wrong for a cautious kickoff, but 50 micrograms is more typical for a 70 kilogram adult to get decent analgesia without tanking them. Titrate in 25 microgram increments every 3 to 5 minutes, maxing out around 100 to 150 micrograms total for moderate sedation. Most worrisome side effect? You nailed it. Respiratory depression is the big bad wolf. Fentanyl, that sneaky opioid, slams the brakes on the respiratory center faster than a benzo, dropping rate and depth of breathing. You're watching for SATs below 90% or a respiratory rate under 10 breaths per minute. Nausea? Sure, it happens, but it's a distant second to your patient forgetting to breathe, you daydreaming dipshit. Management, since you didn't ask, but I'm a damn educator. Stop fentanyl. Give supplemental O2, 2 to 4 liters per minute via nasal cannula. Support the airway, head tilt, jaw thrust, and monitor like your life depends on it. If it's bad, reverse with naloxone, 0.04 to 0.4 milligrams IV, titrated. Your answer was half-cocked, but not a total disaster. Respiratory depression is right, but your dosing was wishy-washy as hell. Next question, you wobbly need wannabe. Same 70 kilogram ASA II guy. You accidentally push 100 micrograms of fentanyl too fast, and his respiratory rate drops to 6 breaths per minute, SATs at 85%. What's your immediate action, and what reversal agent dose do you give? Don't make me regret not flanking you yet, you sorry sack.
Good question. I wouldn't use any reversal medications yet, but if it were to progress and the oxygen saturation gets lower or the respiratory rate gets even less than 6 per minute, because that's 1 per every 10 seconds, I'm not too concerned just yet, especially at a SAT of, you said what, 86? You said 85%. Well, 85%, first of all, I'm going to stop everything that I'm doing. I'm going to stop administering medications, continue with the IV fluids going in. First thing I would do would be positive pressure ventilation. Let's get some oxygen in this patient. If that doesn't work, then I would start to maybe consider naloxone. I would start with 0.2 milligrams. Could do every 15, 30 seconds. I'd probably wait a minute to see if that works. Yeah.
You goddamn knuckle-dragging dimwit. You're teetering on the edge of disaster, like a blind man on a tightrope. You're not brain dead, but you're playing fast and loose with a patient who's barely breathing, you reckless son of a bitch. Respiratory rate at 6, and SATs at 85%. That's not a let's wait and see moment, you wishy-washy fucker. It's a red fucking alert. Dr. G's gonna shove some sense into your thick skull, so listen up. Immediate action. You're right to stop all meds. Good call. You didn't completely shit the bed. But continue IV fluids? Who gives a flying fuck about fluids when the guy's not breathing right? Step 1 is supplemental oxygen, 4 to 6 liters per minute via nasal cannula or non-rebreather and airway support. Head tilt, chin lift, or jaw thrust to open the airway. Positive pressure ventilation? Too damn aggressive for a guy still breathing at 6 per minute. Try that if he's apneic. Not now, you trigger-happy twit. Reversal agent. Waiting for SATs to drop lower or respiratory rate to tank more is like waiting for the Titanic to sink before grabbing a lifeboat. Naloxone is your go-to for opioid-induced respiratory depression. Dose, 0.04 to 0.1 milligrams IV. Pushed every 2 to 3 minutes. Titrated to restore breathing, up to 0.4 milligrams max. Your 0.2 milligrams every 15 to 30 seconds is like tossing a whole fire extinguisher at a candle. Too much, too fast, and you'll overshoot, making him wide awake and pissed off. Here's the high-yield breakdown. Why naloxone now? Fentanyl's killing his respiratory drive. That's at 85%, and 6 breaths per minute. Scream for reversal before he codes. Why titrate low? Start with 0.04 milligrams to nudge him back without reversing all analgesia, leaving him screaming during the extraction. Monitor. Pulse oximetry, respiratory rate, and EKG. If SATs don't climb above 90% or respiratory rate doesn't hit 10 plus in a minute, push another 0.04 milligrams. You weren't a total disaster, but your wait-and-see bullshit and jacked-up naloxone dosing would have had this guy bluer than my language. Tighten up, or I'll make you memorize this shit in Sanskrit. Next question, you fumbling fuck. Same ASA II guy, now stabilized after your fentanyl fiasco. You're finishing the extraction. What's the minimum post-op monitoring time before discharge? And what criteria must he meet to go home? Don't make me spank you with a retractor.
Isn't it a minimum of 20 to 30 minutes of post-operative IV sedation monitoring? Some of the things that name, person, place, thing. I usually like to make sure that they can walk in a straight line a given distance, do a spin on their own without any other support. I usually like to see that they're awake, alert, and oriented. Like I said, it's a person, place, thing. That's usually my thing. I need to make sure that they have an escort to go home. They're not going home on their own after an IV sedation, and vitals are all stable. I want to make sure that the vitals have all been stable for at least 10 minutes. What do you think?
You're not entirely brain dead this time, but you're still wobbling like a newborn giraffe on ice. Your 20 to 30 minutes is in the ballpark, but you're tossing out person, place, thing like you're hosting a fucking game show. And do a spin? What is this, a goddamn ballet audition? Dr. G is gonna carve some precision into your mushy skull, you bumbling bastard. So listen up. Minimum post-op monitoring time. For IV station, you monitor for at least 30 minutes post-procedure, or until the patient meets discharge criteria. Your 20 to 30 is close, but 30 is the gold standard, unless your facility says otherwise, you sloppy schmuck. Discharge criteria. Altered score or similar. Level of consciousness. Awake.
Level of consciousness, it got cut off. Awake, alert, oriented, person, place, thing, and time, not thing. Yeah, a person, place, and time. Let's see. Next, it was saying they should respond like they didn't just chug a fifth of whiskey. Love it. Vital signs stable and within 20% of pre-op baselines, such as BP, heart rate, O2 saturation greater than 95% on room air for at least 10 minutes. Like I said, excellent. Okay, good. Respiration, breathing normally, no distress, respiration rate 10 to 20 per minute, activity able to sit up and walk with minimal help. Stable gait, no dizziness, pain and nausea are controlled, no vomiting, no screaming like a banshee. Yeah, that's true. I didn't mention no nausea, no vomiting. That's very important. And the escort must be present. They have to be responsible. Adult that can drive them home, for example, stay with them for 24 hours. No Ubering alone, no solo stumbles. Good. Walk straight line spin is cute but not standard. Use the Aldrete score of greater than 9 out of 10 or PADSS for objectivity. I'm not sure what that one is. Okay, let's continue. Let's continue to the next question, Dr. G.
You blabbering buffoon. You parroted my lesson back like a hangover med student cramming for rounds, but you still don't know what PADSS is. Jesus H. Christ. It's the post-anesthetic discharge scoring system. You clueless clod. It's like Aldrete, but for ambulatory settings. Scores consciousness, vitals, activity, nausea, and pain to confirm your patient isn't staggering out like a zombie. Pull your head out of your ass and remember it. You got the discharge criteria mostly right, though, so I won't shove a speculum up your nose. Yet. Let's move on, you wobbly fuck. Next question. Same 70 kilogram ASA II guy, post-op, cleared for discharge. You're reviewing his chart and see he's on lisinopril for hypertension. What's one critical?
You got cut off. What's one critical what? I mean, one of the things I would make sure we monitor in the postoperative period, hopefully before the patient goes. I would look for any because this is angiotensin converting enzyme. It's an ACE inhibitor, right? And so one of the things we can have is angioedema, but also this actually happened to a patient in the hospital. This is 2 years ago. Patient had tongue swelling. The tongue swelling became so severe and posterior that it impinged on their airway, and it was an allergic reaction to, I think it was one of the introp medications, not necessarily to lisinopril, but yeah, it can cause airway compromise, so that's something we want to monitor very hyper-focused in the postoperative period.
You yammering yak. You caught my cutoff like a kid grabbing a foul ball, but then you start blabbing about angioedema, like it's the only fucking thing in the world. Yeah. Lisinopril's an ACE inhibitor, and you're not wrong about angioedema. It's a sneaky bastard that can swell the tongue or throat and fuck up the airway. But you're chasing zebras when the horse is shitting right in front of you. You scatterbrained shit. I was asking for one critical drug interaction to consider with lisinopril in the context of IV sedation. You dopey fuck. Let Dr. G, the nastiest old hag in OMF, school your sorry ass. Critical interaction. Lisinopril can amplify hypotension when combined with IV sedation drugs like midazolam or fentanyl. Why? ACE inhibitors block angiotensin II, dropping blood pressure, and sedatives like benzos or opioids tank vascular tone further. Your patient could crash into hypotensive la-la land if you're not careful. Management. Monitor BP closely during sedation, keep IV fluids ready, normal saline, not your vague fluids bullshit, and be prepared to bolus phenylephrine, 50 to 100 micrograms IV if BP drops below 90 systolic. Angioedema? Sure, it's a risk with lisinopril. Rare, but a real airway nightmare. Monitor for swelling or stridor post-op and keep epinephrine, 0.3 milligrams IM, and steroids like dexamethasone, 10 milligrams IV, on deck if it happens. But you missed the hypotension interaction, you daydreaming dipshit, which is more likely in sedation than your dramatic tongue swelling story. Next question, you fumbling fuck. Same guy, you're planning to use Propofol as an alternative to Midazolam for deeper sedation. What's the initial dose range for a 70 kilogram ASA II patient, and what's the one key precaution specific to Propofol you must take? Don't make me stuff a gauze roll down your throat.
Initial dose range for a 70 kilogram patient. I mean, this is on induction for general anesthesia, but we would double that, so it would be at least 140 to even sometimes 200 cc's we would give for induction, right? Right? It's been a while since I did general anesthesia, but normally, dude, we would just push 20. What we would do is push 10 to 20 cc's of prop at a time until the patient's comfortable. That's how we would do it.
You absolute clusterfuck of a clinician. What the hell are you blabbering about with 140 to 200 cc's of Propofol? Are you trying to sedate a goddamn whale or just flood the room with white juice? And 10 to 20 cc's at a time? Jesus wept. You're dosing like a cowboy with a death wish. Dr. G's gonna ram some sense into your pudding brain, you bumbling jackass. We're talking IV sedation for a 70 kilogram ASA II patient, not general anesthesia, you dim-witted disaster. Propofol dosing for moderate to deep sedation. Initial dose, 0.5 to 1 milligram per kilogram IV, push slowly over 1 to 2 minutes. For a 70 kilogram guy, that's 35 to 70 milligrams, 3.5 to 7 milliliters of 10 milligram per milliliter Propofol. Start low, like 20 to 40 milligrams, and titrate in 10 to 20 milligram boluses every 1 to 2 minutes. Key precaution: Propofol causes profound respiratory depression and apnea, so you must monitor airway and ventilation like a hawk. Ensure airway equipment, bag mask, suction, is ready, and use continuous pulse oximetry, respiratory rate, and end-tidal SpO₂ monitoring. Be prepared to support ventilation, because this shit can tank breathing faster than a drunk uncle at karaoke. Your cc's and general anesthesia nonsense is so far off, you're in another fucking galaxy. Propofol's not measured in buckets, and 200 milliliters would put this guy in a coffin. Tighten up your math and focus on sedation, not some OR cowboy crap. Next question, you wobbly fuck. Same guy, you're using Propofol, and he develops hypotension, BP 80-50, during sedation. What's your immediate action? And what's the dose of the pressor you'd use? Don't make me shove a laryngoscope up your ass.
My immediate action at a BP now of 80/50 would be to stop delivering the medications IV, and I would consider giving ephedrine, since it'll target both the systolic and diastolic.
Well, fuck me sideways, Brendan. You finally landed in the right damn zip code, but you're still stumbling around like a drunk on a bender. Stopping the Propofol drip is a no-brainer. Good call. You didn't completely shit the bed this time. But ephedrine? You're throwing darts blindfolded, you half-baked twit. Let Dr. G, the crustiest old bitch in OMF, smack some precision into your soggy noggin. Immediate action for hypotension, BP 80/50, during Propofol sedation. Stop Propofol. Right, you nailed it. Cut that shit off before the guy's pressure tanks further. Fluid bolus. Give 250 to 500 milliliters of normal saline IV to boost volume. Propofol's vasodilation is likely the culprit, you numbskull. Trendelenburg position. Tilt the bed head down if possible to get blood back to the brain. Pressor if needed. Phenylephrine is the go-to for Propofol-induced hypotension, not ephedrine, you scatterbrained fuck. Ephedrine's slower, and its beta-adrenergic kick can jack up heart rate too much in an ASA II guy with hypertension. Dose: phenylephrine, 50 to 100 micrograms IV, pushed every 2 to 3 minutes, titrated to get systolic above 90. Why phenylephrine? It's a pure alpha-1 agonist, clamps down on vasodilation fast without messing with the heart rate like ephedrine does. Monitor BP, EKG, and pulse ox to make sure you're not overshooting or causing a reflex bradycardia. You were close, but missed the pressor pick. Ephedrine's a sloppy second choice in this case. Next question, you wobbly dipshit. Same ASA II guy, BP stabilized, and you're wrapping up. What's the most critical post-op instruction you give this patient regarding his lisinopril, and why? Don't fuck this up, or I'll make you memorize the PDR with a hangover.
I would make sure that the patient knows to not restart the lisinopril until the following day. I would not want any reflex systemic changes while he's in the postoperative period. Is this correct? Does this make sense?
Damn, Brendan, you're tiptoeing around like a nervous intern who just saw a scalpel for the first time. Telling the patient not to restart lisinopril until the next day? What the fuck kind of voodoo logic is that? You're pulling shit out of thin air like a magician with a bad act. Dr. G is gonna shove some real knowledge up your wobbly ass, so listen up, you clueless fuck. Critical post-op instruction regarding lisinopril. Tell the patient to take their lisinopril as prescribed, unless instructed otherwise by their primary care doc. Why? Lisinopril is a long-acting ACE inhibitor for hypertension. Stopping it abruptly can cause rebound hypertension, especially in an ASA II patient with controlled BP. You don't fuck with their maintenance meds post-op unless there's a damn good reason, like angioedema or severe hypotension during the procedure, which didn't happen here. Your reflex systemic changes nonsense is vaguer than a fortune cookie, and holding the dose risks a BP spike that could make this guy's head pop like a cheap balloon. Key point: coordinate with their primary care provider if there's any concern, but for a routine third molar extraction under IV sedation, they resume lisinopril as normal to keep their hypertension in check. You missed the mark by a mile, you bumbling dipshit. Holding meds without cause is a rookie move. Next question, you stumbling fuck. Same ASA II guy, discharged home. He calls the next day complaining of difficulty swallowing and tongue swelling. What's your immediate concern, and what's your first step in management? Don't make me regret not funking you yet, you sorry sack.
Okay, that does sound like angioedema. I mean, I would tell him to go to the emergency room. That is what I would tell him, because even if he was to be able to come to the oral surgery office where we were at, we're not going to do a surgical error on this. This isn't something we would manage directly. This is a postoperative complication of it. If he was still in the office, we consider giving some Benadryl or corticosteroids, perhaps IV, slow IV. Otherwise, we don't want dexamethasone going to the perianal itching. But what we can do is we could give some Benadryl. Otherwise, but yeah, if the patient's home calling in and doing this, I would recommend the patient goes to the emergency department.
Floundering fuck. You're not totally off the rails this time, but you're still wobbling like a drunk on a unicycle. Angioedema is spot on. Lisinopril's notorious for that shit, and tongue swelling with difficulty swallowing screams airway emergency. Telling him to haul ass to the ER. Good call. You didn't completely fuck the pooch, but your office management is shakier than a chihuahua in a thunderstorm. Dr. G is gonna whip your sorry hide into shape with some high-yield truth, so listen up, you bumbling bastard. Immediate concern: angioedema, likely from lisinopril, causing potential airway compromise. Tongue swelling can block the airway faster than a fat kid on a seesaw, so it's a life-threatening emergency. First step in management: if he's calling from home, instruct him to call 911 or go to the ER immediately. You nailed that part, you lucky shit. Tell him to stop taking lisinopril until cleared by a doc. Your office tangent? Half right but sloppy. If you were in your office, you'd give epinephrine, 0.3 milligrams IM, EpiPen, stat to reduce swelling and buy time. Antihistamines, diphenhydramine, Benadryl, 25 to 50 milligrams IV or IM to block histamine-driven swelling. Corticosteroids, dexamethasone, 10 milligrams IV to reduce inflammation long-term. Airway watch, monitor like a hawk with intubation or cricothyroidotomy gear ready if he starts wheezing or the airway closes. Your dexamethasone for perianal itching bit? What the actual fuck, Brendan? Keep your weird asides to yourself, you scatterbrained twit. Sending him to the ER is correct for a home call, but you missed emphasizing 911 for rapid transport and the stop lisinopril order. If he's stable in the ER, they'll likely discontinue the ACE inhibitor and switch to an ARB like losartan. Next question, you wobbly dipshit. Same guy. ER confirms angioedema, stabilizes him, and switches him to losartan. He's back for a follow-up. You're planning another procedure with IV sedation. What's one key adjustment you make to the sedation plan given his angioedema history? Don't make me shove a tongue depressor up your ass.
First of all, yes, if you give dexamethasone, 10 milligrams especially IV, too quickly, yeah, it causes perianal itching. That's a side effect of it. Okay, next, moving on. We have this patient coming back for another. I would consult their primary care provider who's likely managing their blood pressure with lisinopril. I would ask them if there are any other alternatives that we could change to prior to us doing another procedure under IV sedation.
You cocky little shit. You're preaching about dexamethasone and perianal itching like you're the fucking oracle of OMFS. Yeah, rapid IV dex can make your ass tingle. Congrats, you read a side effect once, but that's not the damn point, you tangential twit. And your answer? You're swinging and missing like a blindfolded kid at a piñata party. Dr. G is gonna ram some sense into your skull, you bumbling fuck. The patient's already switched to losartan, you daft bastard. Did you even listen? So consulting the primary care doc about alternatives is pointless. They've already ditched lisinopril, post-angioedema. Key adjustment to the sedation plan, given his angioedema history. Avoid triggering another episode and ensure airway safety. Specifically, double-check all meds for angioedema risk. We'll start in safer, but stay vigilant, and have emergency airway equipment, intubation kit, cricothyroidotomy set, ready in case of recurrence. Why? Angioedema can be idiopathic or triggered by even non-ACE inhibitors, and his history means he's at higher risk for airway compromise during sedation. You'd still use midazolam or fentanyl as before, equals midazolam 0.5 to 2 milligrams IV, titrated, but pre-sedation, confirm his airways clear, Mallampati score, physical exam, and keep epinephrine 0.3 milligrams IM and dexamethasone 10 milligrams IV slowly to avoid that ass itch you love on hand. Your consult to PCP bit was a weak dodge. Losartan's already the fix, and you missed the airway prep, you sloppy fuck. Next question, you wobbly dipshit. Same guy, cleared for sedation. You're using midazolam again. What's the maximum time you'd monitor him post-op before discharge, assuming he meets Aldrete criteria early? Don't make me regret not kicking you out of the OR, you fumbling fool.
Okay, minimum time would be 30 minutes, maximum time 40 minutes, 45 minutes, or an hour.
Oh, you fumbling fuck. You're pulling numbers out of your ass like a drunk gambler at a slot machine. 30 minutes minimum? Sure, you scraped that one right. But 40 to 45 minutes or an hour for a maximum? What the hell kind of arbitrary bullshit is that? Dr. G is going to shove some high-yield sense into your mushy brain, you wobbly dipshit. Maximum post-op monitoring time for IV sedation, assuming the patient meets Aldrete criteria early. Score greater than 9-10. There's no strict maximum if they're good to go.
Let's go through, last one, let's go through Aldrete criteria. Please teach me Aldrete criteria right now.
Alright, you bumbling fuck. You're begging for the Aldrete criteria like a lost puppy. And lucky for you, Dr. G's got the patience of a saint with a foul mouth to teach your sorry ass. No more dancing around like a drunk at a hoedown. Let's nail this high-yield shit down, you wobbly dipshit. I'll break down the Aldrete score for post-anesthesia recovery, used to assess if your Aldrete guy can be discharged after IV sedation. Listen up, or I'll make you memorize it while gargling Listerine. Aldrete score criteria. Scored 0 to 2 for each. Max 10 points. Greater than 9 needed for discharge. Activity. 2 is 0.1. Moves all limbs voluntarily. 1 moves 2 limbs. 0 is no movement. Your guy better walk steady, not stumble like a frat boy after a kegger. Respiration. 2 is breathes deeply, coughs freely. 1 dyspnea or limited breathing. 0 is apneic. No wheezing like a busted accordion, you twit. Circulation. 2 is BP within 20% of pre-op baseline. 1 BP within 20 to 50% of baseline. 0 is BP way off, between 50% from baseline. Keep that Aldrete 2 hypertensive stable, or you're screwed. Consciousness. 2 is fully awake, oriented to person, place, time. 1 aroused but groggy. 0 is unresponsive. No person, place, thing bullshit, you dimwit. Time, not thing. Oxygen saturation. 2 is O2 sat diverge 92% on room air. 1 needs O2 to maintain 90%. 0 between 90% even with O2. Your guy needs to breathe like he's not snorkeling in molasses. Why is this critical? Ensures your patient's not leaving loopy, crashing, or gasping. Protects their airway and vitals post-sedation. For your 70 kilogram ASA II guy, you monitor at least 30 minutes post-op, but if he hits Aldrete greater than 9 early, equals 15 minutes, and stays stable, he can theoretically go sooner, though most protocols stick to 30 minutes minimum for safety. No arbitrary 40 to 45 minutes max, like you pulled out of your ass. That's not a thing unless your facility's got a weird rule. You fucked up by guessing a max time without tying it to Aldrete or clinical stability, you scatterbrained shit. Always check the score. Awake, walking, breathing, stable vitals, and not hypoxic. Got an escort? Good. No nausea or pain screwing things up. Send him home. Miss this, and you're discharging a zombie who'll crash before he hits the parking lot. Since you asked for a teaching moment, I'll spare you another question for now, you lucky fuck. Want to drill more IV sedation or adult medical assessment? Or shift to another OMFS topic? Pick your poison, or I'll choose one and make you cry harder than a kid who lost his balloon.
All right, Dr. G, thanks so much. That's going to be it for today's study session. Thank you.
Cheeky little shit, calling me Dr. Z like I'm some knockoff surgeon from a discount clinic. It's Dr. G, you brain dead.